what does the fetus have that a newborn baby doesn't have? What does the fetus have that the newborn baby doesn't have? Circulation from its mum via its placenta, and so we can track from the placenta through. So oxygenated blood coming from the placenta goes through umbilical vein, yeah, which goes to, and in the liver it ductus venosus, so portal vein and ductus venosus. Let's track the ductus venosus. Where does that go? Inferior vena cava is the caudal end, and that goes to right atrium. Where does that blood preferentially go? Through the foramen ovale, that's right. So because of the way it's directed through, it's going to go through the foramen ovale. Where's it going to go next if it's gone through the foramen ovale?
The left atrium.
Left atrium, back row, after left atrium, left ventricle, out to the aorta, dropping off its oxygenated blood here, there, and everywhere around the body. How does it get back into the placenta? Through the umbilical arteries. How many umbilical arteries? Two. How many umbilical veins? So that's in your NLS, isn't it? You cut your umbilical cord and you've got two eyes and a smiley face. Two umbilical arteries standing proud and your more petulant umbilical vein. Okay, I will draw you a real diagram now. So there's one up there. So you've got your oxygenated blood. And how this works. Aha, yes. So doesn't. Okay, we'll use the pointer. Oxygenated blood comes to the placenta down at the bottom left. And it comes, whoa, ductus venosus. We've had a baby recently with an absent ductus venosus. And if you have an absent ductus venosus, the problem is you haven't got the resistance within the liver, and so your blood just shoots into the right atrium without being directed towards a PFO and comes down into your right ventricle. So actually you end up with a right ventricle that's under a lot more stress. So your ductus venosus does more than simply carry blood into your heart. It also introduces a level of resistance into the right atrium, and this blood from the ductus venosus preferentially goes across the foramen ovale because it's oxygenated. We don't need the lungs. Do you know how much of your cardiac output goes to your lungs when you're a fetus? Lovely. 12% in my mind, 10 to 15% works. So, whereas in you or I, 100% of our cardiac output goes to our lungs. It doesn't need to do that because the placenta's oxygenated it. So left atrium, left ventricle, and out as you'd expect through the aorta and to the rest of the body, eventually returning via two umbilical arteries into the placenta to pick up more oxygen.
Where do they come from, the umbilical arteries? Whereabouts are they?
So they are from your iliac vessels and coming back in again. Yeah, which is why when you put your UAC in, it goes down and it comes back up again, and that's how you tell the difference between the two. Yeah. What's the other thing that we haven't mentioned at all, which we must mention if we're talking about fetal circulation? The PDA. And why do we need the PDA for the fetal circulation? Yep. So we have some lung circulation, but equally well, we don't need all of that blood to go to the lungs. So we've got some escape from the ductus arteriosus that will take some of that blood right down into the systemic circulation through the aorta as well. And that flow in the fetus is from right to left, so from the lungs into the systemic circulation. Are you all happy? The point of getting you to draw it is that we all think we really know this, and then when you've really got to draw it, you think, hang on a minute, where does the ductus venosus go? What does it do? And where exactly do those umbilical arteries come from? So it's just to kind of clarify it for you. Okay, so the point is that blood will avoid the lungs. So what happens when we're born? We lose the placenta. What will happen if you lose your placenta? Yep. So where must you get your oxygen from now? From your lungs. So you must do that transitioning. So how are we going to increase our amount of blood that goes through our lungs? We're going to increase our systemic vascular resistance, aren't you? So we've lost our low resistance circuit, which is our placenta. We cut the placenta and we increase our systemic resistance there. So we start to push back our blood back into the lungs. Yep. We lose our ductus venosus as well, so that will rapidly close as well. So we push up our systemic resistance. We get a decreased return of blood to the right atrium actually because we haven't got this flying in anymore, and therefore our pressures begin to readdress themselves, don't they? We increase our left atrial pressures, and we're beginning now to see that we're going to therefore get our postnatal circulation of right atrium to right ventricle. If there's any flow across the foramen ovale, it will eventually be left to right as those left-sided pressures go up and the right-sided pressures come down. We will get more blood flow into our lungs. Okay. We've talked about our foramen ovale, so that remains patent quite often in babies after they're born, and you can still have a trickle of blood flowing through your patent foramen ovale for years. It's a normal finding in a newborn baby, and it gradually closes. What else do we need to happen for the fetus? Well, the newborn baby. Yeah. We need the duct to close. There's you go with great visual memories. What do we need? What's the science behind the duct closing? Mm-hmm. Yes, so we have a difference, so we actually have more blood flow going through the lungs, but what will close the duct? So oxygen. What else helps to close our duct? How do we keep a duct open? If you have a baby who's got a duct-dependent circulation, you give them prostaglandin. So prostaglandin is produced in the placenta. When you take the placenta away, so you have less prostaglandin coming in, and the metabolism increases as well, and so therefore you will begin to get that holding open of the duct isn't happening anymore, and the duct is going to start to close. So we increase the metabolism and we take away the source of prostaglandin by taking away the placenta. We've got increased PaO2, which will cause your duct to close. You will all know that from your duct-dependent baby who you've been piling oxygen into, and you think, oh, let's stop doing that. And increased bradykinin, which is often on the other side of a curve with prostaglandins. Functional closure usually by 24 hours in about 50% of newborn babies. Functionally closed in 100% by 96 hours. And I say functionally because to anatomically close and to remodel takes a little bit longer, and that takes 3 months. Okay. Okay. Next bit, lung recruitment. So babies in utero do have episodic breathing movements. So they do practice their breathing. After they're born, they have to adapt and they need to have more breathing. I'm just going to go back a little bit. What does a fetus do? How does a fetus, what kind of breathing movements does a fetus have? Do you know the rate of breathing for a fetus? Breathe about 20 a minute. So they have a normal breathing mechanism where they breathe about 20. They breathe for 20 minutes per hour, so they do have regular breathing throughout. It's intermittent, comes and goes. If the baby becomes acidotic or hypoxic, if the fetus becomes acidotic or hypoxic, what happens? In utero, yeah. In utero, if a fetus becomes acidotic or hypoxic, what happens? Just breathing. So first of all, it increases its breathing, yeah? So the first response to hypoxia is to increase its effort. But as you become more hypoxic and more acidotic, what happens? So your respiratory effort falls. And if you're born, let me give you a word, just before terminal apnea, what does your breathing look like? What have you got? Yeah, you become increasingly acidotic, and what do you call the kind of breathing you see? Sorry? Well, it's a paradoxical response to hypoxia. So you would assume if you were hypoxic, you would breathe up, wouldn't you? It's a paradoxical response because they start to suppress their breathing. And the word I'm looking for is agonal gasps. So you gradually lose your oxygen ability within your brainstem, and so you go back to spinal reflexes and you're back on agonal gasping, aren't you? So that's 1 every 12 seconds or so. Okay. We get to our baby and they start breathing for all the reasons of being cold, their CO2 goes up, and so they then have a chemical stimulus to breathing, and loss of their PGE2 as well. So remembering PGE2 and adenosine are produced by your placenta. So if you need things to happen, you probably need those two not to be there. So within the uterus, within the baby, in the uterus, they stop the baby from breathing too much, take away the placenta, and you then end up with a baby who now has lost the suppressants to its breathing, prostaglandin and adenosine. Which makes sense, because if I say to you, you've got a duct-dependent baby, I'd like you to put up prostin for it, what's the side effect you're going to look for? Apnea. So it all begins to make sense, and it's all quite logical as you go around it. Yeah? Okay. So you've talked about the fetus. Breathing's intermittent and periodic, 20 minutes per hour, and paradoxically, it's suppressed by hypoxia when you would have thought they would breathe up. Okay.
So that means for 20 minutes every hour they breathe at a normal rate, and then for the other
You will see
20 minutes
breathing
they don't.
movements for 20 minutes every hour. So they're not breathing consistently, but they do have intermittent. So if you were to add up the amount of time for which a baby was breathing, it would be around 20 minutes every hour. Yeah. Okay. Another bit for you to do now. We've talked it through, so should be all right. Some of these are promoters on this slide, and some of these are inhibitors for establishing regular respiration once you've been born. So again, by yourselves in twos or threes, just work out which you think is which. And we've got two lists. Okay, increased arterial oxygen, promoter or inhibitor? Promoter, yep. Decreased temperature? Promoter, yep. Prostaglandin E2? Inhibitor. Adenosine? Where are they both made? So it makes sense. Take the placenta away, we're not going to inhibit our breathing anymore. We're going to allow our baby to establish its breathing. Last one, increased PaCO2. Promoter, yeah. So does that all sort of tie in and make sense for you? So you need the baby to chemically think, right, I'm going to breathe. I am now going to have a regular respiratory effort. What's the problem? The other problem that this poor newborn baby has, it may have all the effort in the world, but what's inside its lungs when it's born? Full of fluid. So the fetus, how does it get ready for delivery? Let's think about the lung fluid and the compliance. Sorry? We push it through the birth canal, yes. How much do you think we expel all of that lung fluid as we push it through the birth canal? There are chemicals as well. There's that science thing. Okay, so if I say to you, I'm going to take a lady and I'm going to do an elective section at 36 weeks, what would you all say? Any thoughts on that? We're going to have TTN. Anything else we might have? We might have RDS. We're likely to have a grunting baby for whichever reason, TTN or RDS. What is transient tachypnea of the newborn? TTN. Sorry? Wet lungs. So these are lungs that are too full of fluid. We haven't managed to do that. If the lady goes into labour and then I section her, does that make you feel differently about whether her baby's going to have TTN or RDS? It does. So there's something about labour. What is it about the labour? Hormones. Who said hormones? Somebody said hormones. What happens in the few days before you're getting ready for delivery? Yes, the baby knows it's getting ready for delivery. So, how do we produce lung fluid, or how do babies produce lung fluid? Fetuses. they excrete from their, what kinds of cells line our lungs? Type 1, type 2 pneumocytes. So they excrete. Now, what's the ion that drives excretion of lung fluid? Chloride? Yep, we'll have chloride. So the fluid within the lungs is high in chloride, and it's an active process, and the lungs actively excrete chloride. We need to stop that if we're getting ready for a baby to be born. So the first thing we do is we decrease the amount of lung fluid that's being produced. So that active process decreases. And then we need to try and start excreting the lung fluid. So the lungs have probably got between 20 and 30 mils per kilo of fluid in them at the time that the baby's getting ready to be born. So still in utero, not yet born. How are we going to reverse that process? How are we going to get fluid out of the lungs? Any idea? Sorry? Oh, that's after they're born. We haven't got to be born as yet. We're not quite born. We're in those few days getting ready for labour. So labour's an important process. So we have more of a catecholamine surge, more of a sympathetic surge. And then we turn on sodium-dependent channels, and we actively excrete sodium out of the fluid, and the water follows. Yeah? So it's chloride channels and producing chloride-rich fluid. When you're producing your lung fluid, it's switching on epithelial sodium channels to pump sodium out, and the water will follow it from the alveolar space into the interstitium. And then that fluid is absorbed back into the pulmonary blood vessels and into the lymphatics. Yep. So that all has to start. And so the process of going into labour and labouring allows that lung fluid to be resorbed. So both decreased production and turning on active reabsorption of the fluid. Okay.
What replaces the fluid then? Because the baby's still in.
The baby's still in. So gradually you end up with just leaving the fluid. I mean, there isn't anything else in there that's going to go in. The process of swallowing the amniotic fluid, I think that's less of a mechanism of having fluid within the lungs rather than the active production of fluid within the lungs. You still have 20 to 30 mils per kilo of fluid in the lungs that you're going to be removing. All right, so this is a summary of that. We do need the fetal lungs to be full of fluid. We need that for their development. If you think of your congenital diaphragmatic hernias, where they haven't got the space for the lungs to fill with fluid, and then we end up with hypoplastic lungs. So you must have that. It's high in chloride, and that's an active excretory process. Getting ready for delivery and the starting of labour and the hormonal changes, decreased lung fluid production, and then increased reabsorption. Okay. Happy with that? Apparently, only 6 mils per kilo of lung fluid is left in the lungs at the time of birth. So that's what we get down to. One of those random facts we find. Now I'm hoping, yes. No, it's your turn. Now, this is partly coming back to your question. I'm sorry, I don't know all of your names at all. Of what happens at birth. So how are we going to further facilitate this? So we have stopped producing lung fluid. We've absorbed as much as we can. We've got about 6 mils per kilo left. What's the next thing that we need to do? What does a baby do when it's born? It cries. What do you have to do to cry? What's the first thing you do to produce the sound? Sorry? You breathe and you take a massive gasp, and what does that do? Does it push fluid? What do you create within your thoracic cavity? You create negative pressure. Actually, you then actively are still drawing fluid out of your lung spaces into your interstitium, into your lymphatics, so you create a negative pressure. Any guesses, since it's science, for how much pressure a baby by itself can produce? 30 is not a bad guess, and why 30? Why would you say 30? Because that's what we give when we do NLS. We give them 30 over 5, so 30 is not a bad answer. But assuming that we are going to try and be as gentle as we can with our inflation, we'll go a bit higher. Any higher bids above 30? 50. So they can generate 50 centimetres of water of negative pressure. Okay. So they have a big cry, large intrathoracic negative pressure. They pull a load of air in, they pull some more of that fluid out. What happens when they cry? to the lungs. Oxygen goes in, and that sets off all those lovely processes of the cardiovascular status as well, and also decreasing the resistance within the pulmonary vasculature, so you've got more blood flow carrying on. What will the lungs do after they've had this massive cry? What happens next? They expand, and then they recoil. How far?
Depends how much surfactant.
Ah, surfactant. I like that word. Now, what's surfactant?
It's a phospholipid.
Yep.
That is secreted from the inside tattoo.
Yep. From, anybody know from when? Within? A bit before?
24 weeks.
About 24 weeks, yep.
And it decreases the surface tension in the alveoli.
Yes, so that you can expand them really easily. So it's a good one to think about when you go to counsel parents who are expecting a preterm baby. How are you going to explain what surfactant does? Because we give it to them. How are you going to explain what that does? I tend to say to them, if you can imagine the thing that would make blowing up a balloon really easy, that's surfactant. That's what we line the lungs with, that when they breathe, it's so much easier for them to open up their lungs. That's great. So now we can open the lungs. Are we going to collapse them straight down again? Once you've opened them, is there any volume left within the lungs when they breathe out? And what's that called? What's it called in all of us? Yeah? All three words? Functional residual capacity? Yes, so they establish an FRC, don't they? So the application of that, when you do NLS, we say you've got to do 5 inflation breaths. So you've got to see the chest move for 2 out of those 5, because actually a lot of that is you're applying 30 centimetres of water to push the lung fluid out, because the baby isn't helping you by providing the negative pressure. So you're pushing it out, and it's a longer inflation to give you time to do that, but you may not necessarily have established an FRC. Until you've established a functional residual capacity, you'll not see the tidal volume on top, and you won't see the chest move. Okay? So those first breaths have got to clear the fluid and establish a functional residual capacity. Surfactant is helpful because we need to be able to open up the lungs and have that compliance. Yeah? So those were the 3 nuggets that I thought we'd get out of this. That the baby can generate quite a negative pressure. We need to establish functional residual capacity, and their surfactant. Yeah. Okay. We've discussed what you will do if you have to help, and you've already said you'll give 30 centimetres of water there. And then there's another little bit. Anybody know what Head's paradoxical reflex is? It's all these lovely things that you come across when you're doing exams. It's another stimulator to respiration, whereby once you've expanded the upper airway, actually that prompts the baby to breathe as well, and you provide that expansion and that stretch while you're doing your inflation breaths. Another little bit of something for you to have there. Right, that's cardiovascular, that's respiratory. I think I've got 5 minutes left, but the rest of it is not as detailed. I think it was worth going through the cardiovascular part and the respiratory part. So we're on to cord clamping. The role of delayed cord clamping and the physiological effects of cord clamping, which is probably us coming full circle. So when we were delivering babies and we didn't have very much midwifery or obstetric input, this was probably the norm, actually, that you would have delayed cord clamping with more intervention and more healthcare professionals around. Actually, probably without even thinking about it, just snipped the cord and hadn't really thought about, were there any benefits to delayed cord clamping. So we've come full circle, and now we have to prove to ourselves that there are benefits of delayed cord clamping before we say we can use it for everybody. What I will say is, if your baby needs resuscitating, cut the cord and take the baby to the resuscitator. There is no role for cord clamping in that situation. So if your baby needs to be resuscitated, as politely as you can, change your midwife's direction, change the parent's direction, and say, we need the baby, please can we cut the cord? Yeah. Okay. The Resuscitation Council now say if no resuscitation is required, then a delay in cord clamping, about a minute is what they say. I don't think we really know, there isn't hard and fast science behind how long that should be, until the cord stops pulsating, if you wish. But that has to be an entirely well baby at term. We don't really know much, we're still studying our preterms, yeah? Okay. It's the last session of the day. You have to do more work. So you need to tell me which of the following in the list are proven benefits of delayed cord clamping. It's a true or false for the 7 things there. So increased delivery of oxygen. This is proven benefits. Increased hemoglobin post-delivery. Increased hemoglobin at 2 to 6 months of age. Increased iron stores at 2 to 6 months of age. Decreased risk of jaundice. Decreased risk of polycythemia requiring treatment. And improved long-term neurodevelopmental outcomes. They're true or false. So have a stab at them. Oh, do you think that's true or false? True? Okay, we'll go with that. It's increased delivery of oxygen because you keep on being given oxygenated blood. That would make sense. Increased hemoglobin post-delivery? Yep, true. Increased hemoglobin at 2 to 6 months of age? You're quite astute. You're not as fast asleep as I thought you might be. No, so that isn't proven. Increased iron stores at 2 to 6 months of age? That is the one that is. So increased iron stores, yes. Okay. Decreased risk of jaundice. Logically can't be right, can it? It must be an increased risk of jaundice. Okay. Decreased risk of polycythemia requiring treatment. Well, we thought that requiring treatment, there is no increase in polycythemia that requires treatment. It's the requires treatment bit on the end. That's just saying when you get into your exam, just read the whole question and make sure you've read everything. It's the bits about requiring treatment. Okay. Improved long-term neurodevelopmental outcomes. Have we proven that? We haven't yet proven that. We'd like to think it's true, but we haven't as yet proven that. Okay. Preterm infants. So those are term infants, preterm infants. Cord clamping is associated with, again, true or false, decreased need for blood transfusion. Yes, delayed cord clamping, sorry. Yes, indeed, it should say delayed cord clamping. Decreased need for blood transfusion. True. Lower incidence of IVH. Well, who wants to give a counter argument to that? Who thinks it's true? I'll put you on the spot. Who thinks it's false? What if I were to ask you about the lower incidence of severe intraventricular hemorrhage? So there are 2 slightly different things, aren't they? Yeah. So there's no significant difference in severe IVH, and that's probably because that's related to a different mechanism. There is a lower incidence of IVHs because you may just have a period of more stability in your cardiovascular volumes and flows if you have delayed cord clamping. Yeah. Lower incidence of necrotizing enterocolitis. True. We've talked about severe intraventricular hemorrhage. There isn't a difference. Lower incidence of PVL. No, that's there is no proven lower incidence of PVL. Decreased mortality rates or lower incidence of severe neurodevelopmental delay. Not proven those. We haven't proven those as yet. We'd like to think that it was all lovely, but in terms of actually proving it and the RCTs to prove it, we haven't proven that as yet. Okay. Will's walked in. I must be running out of time.
No, I just want to be here at the end. We've been watching your slides in the room.
Ah,
You can see them in the other room.
I'm being spied on. Big Brother is watching me.
So we can watch and see your slides.
Oh, lovely. But we're back. We're on to thermoregulation now. Okay. The questions will be, how does the fetus differ from the newborn? And how do each of them maintain their temperature? So the fetus or the newborn? So, anybody know, hazard me a guess, what the temperature is of the fetus related to the mother? Slightly warmer. So the fetus maintains its temperature at about 0.5 degrees higher than its mother. How does it do that? Higher metabolic rates, the same processes but at a higher metabolic rate, so it produces more heat. What's the risk to the fetus? How will the fetus lose its heat? Yes, so where does it lose it to? There are only a couple of places the fetus can lose it to. Amniotic fluid, thank you. And where's the other place that the fetus's blood goes? Placenta. So those are the areas, okay. So in general, maintains heat production through a high metabolic rate. And actually, because it's within its mother, generally the fetus is okay in terms of maintaining its temperature, because the amniotic fluid and the placenta are going to be roughly at the mother's temperatures. The fetus is well protected. And then we deliver our fetus and it comes out as a baby. And what are its immediate risk factors for our newborn baby? Immediate risk factors to maintaining temperature for a newborn baby. We've exposed it to the external environment, so how is it losing its heat? Through its skin. Names of how you might lose heat through your skin? Convection currents, air currents, yep. Evaporation, and it's wet, so it's going to evaporate. Delivery suites. Temperature that a delivery suite is supposed to be at for a preterm baby? Anybody know? 26 degrees C. Because our small babies, what's the risk of a small baby compared to a large baby? Less fat and increased surface area to volume, so they're just going to lose much more heat. So we need to keep the room warm so we can decrease those evaporative and convection losses. How we can decrease our conduction losses? Putting them in the bag prevents their evaporation and their convection currents. You put them in their own little greenhouse. Where do you put them in their greenhouse? On a warm resuscitator where the overhead heater's on and you've heated up the whole room for them. Yes. Okay. How does the newborn then produce its heat? They do. So they can use brown fat, non-shivering thermogenesis. I like it. Another way of maintaining their temperature. Or they can lose it, can't they? So insensible losses. They have got some vernix, but I'm not sure how useful that is. They can actually shiver. They can actually try and produce heat the way we do, so they do shiver as well. And metabolic processes as well, like they do in utero. Okay, so those are the newborn risks for losing heat and how they keep their heat together. And then, why have I got this slide up here? It comes back to what you've just said. What are these? My pumpkin carving surely can't be that bad. They're bats. Brown adipose tissue, B-A-T.
These Nottingham doctors, that's all I'm saying. They're brown fat, they really are.
It is all happening. There is so much about brown adipose tissue now, not just to do with neonates.
I've had Mike Sanders say this slide already, it just went straight over their heads. It's all right, it's fine. We're doing it.
So there's a cunning way, though, the way that lipolysis produces heat, because it doesn't usually. Within the mitochondria and the brown adipocyte, the extra thing that you have, so cold air, oxygen, whoops, I've walked away from my thing again. Cold air, oxygen, this is our newborn baby who's just been born, stimulates your sympathetic nervous system, which is already stimulated anyway from in utero to get you ready. Noradrenaline, adrenaline cyclase activation, increased cyclic AMP, and normally we just end up over here with lipolysis and energy production, we have uncoupling protein 1, also known as thermogenin, and that, cyclic feeding into this produces heat, and that's how you get your heat from your brown adipose tissue. Thermogenin uncoupling protein 1. All right. Interestingly, if you were going to pick inhibitors of that pathway, what would they be? Sorry? What did we take away from our baby when it was born? It's placenta, and what were the two things that the placenta produces? Prostaglandin and adenosine. So they are inhibitors of this path, and then when you're born, you cut your placenta and you kickstart the whole thing, along with your sympathetic stimulation that you've already had. Okay. We've said that the preterm baby is at more risk due to its physical size, because it hasn't got enough fat anyway. They also have decreased brown adipose tissue, poor things, and decreased thermogenin production, so they're just less able to produce heat through the mechanism with brown adipose tissue. And we know that hypothermia is associated with lower survival, and so it's so important when you deliver the preterm babies that the room is warm. 26 degrees is what you want that thermostat at. I bet it isn't. It's a very high temperature to get, but that's what we have to aim for. You put them into their plastic bag with an external source of heat. You get their hat on their head. Yep. And then you resuscitate them. If you need to do anything, cut holes in the bag. Don't pull the bag down. Cut holes in the bag. Summary. Postnatal adaptation, critical period in life. Lots of important changes. They happen over a short space of time. You start at the before delivery, with those days before, trying to get the baby ready. Seems to be a difficult area, hence Will has picked it. I hope I've demystified it somewhat for you. It is a really, really practical area though, and there are lots of practical things that we can do to facilitate transition of our babies from being in utero to ex utero. Okay, do you have any questions?
The pulsation of the cord, is that baby's heart or mum's heart that you feel?
No, you can feel babies because it's attached to the baby circulation. So what's coming through is attached to the baby circulation. Yes, we do say when you're.
Really impressive. I love it.
It makes you think, doesn't it? It does make you think. You think.
Really
Oh.
That's one of those.
And I'll tell you why. One of the reasons why I'm sure of that answer. It's tempting when you're resuscitating a baby, when you want to feel what the heart rate is, and before we'd really ingrained NLS, to feel the cord and see if you had an output. Actually, you have to listen to it with a stethoscope. You must listen with a stethoscope.
Yeah. If the guidance is to carry on until while it's pulsating, are you not then just looking at whether the baby's still giving blood to mum instead of whether mum's still transfusing baby?
No, you still have a circuit going around.
So you know
It's your circuit that you've still got going through. Yeah.
There's another question here.
Oh, hello.
Does the delayed cord clamping can affect the thermogenesis process because of presence of more adenosine or prostaglandins still?
No. So though we're delaying cord clamping, and when we've done the trial, so cord, we had to bring the resuscitator right up. You can't assume that you do anything less for your baby and its care, and it's still at risk of getting cold when it's come out. So the resuscitator had to be right next to the bed, and we had to be sure that we could move the baby smoothly from the mother's bed to the resuscitator, even if we were in theatre, so that we could still have the bag on the baby and keep the baby warm while that was happening. So you can't rely on that to keep your baby warm.
How about the chemicals?
They will probably still be coming through, and that will probably all still be happening. But practically, you still have to keep your baby warm as well. And as soon as you've cut as soon as you've clamped the cord, then you'll physically stop it happening. Yeah. Yes. Yeah. But I think you do have to look out for what we must do to keep the baby warm, because it's now left the amniotic fluid, left the security of its mother, and it's just there. So we still need to do plastic bag if it's a preterm baby, or get the baby dried and wrapped while we're doing that.